It's time for the 3-question warm-up for Endocrine 2. First question here, what medications other than stimulants are used in the treatment of ADHD, so attention deficit hyperactivity disorder? Now we use stimulants most of the time, but if you can't use those or you don't want to, you might want to think about using Thse, so the tricyclic antidepressants. Bupropion is another one, and then even the alpha-2 agonist clonidine can be used for ADHD. Next, what are the 3 reasons for involuntary psychiatric hospitalization? So you need to know the reasons why you can hospitalize a patient potentially against their will. So the first one is a patient is a danger to him or herself. The second is the patient is a danger to others. And the third is the patient is gravely disabled, or he or she cannot take care of themselves, maybe like a catatonic schizophrenic, can't feed themselves or bathe themselves. Next question, what is the psychiatric condition in which a person travels a long distance, takes a new name, and has no memory of his or her prior life? So this is a dissociative fugue. All right, guys, that brings us to the end of the warm-up. Let's get to that video.
So in this video, now let's move on to type 2 diabetes. All right, let's get going. So the old terms for type 2 diabetes are adult onset diabetes or non-insulin dependent diabetes. Neither of those terms are really correct. So for starters, we know that children, and especially teenagers, can get type 2 diabetes. Type 2 diabetes is associated with obesity and is hereditary. Type 2 diabetes runs in many families, and children are getting fatter and fatter, so we're starting to see type 2 diabetes at an earlier and earlier age. So it's not really always adult onset. And you can be insulin dependent, or at least insulin requiring, in any kind of diabetes. So definitely use the term type 2 diabetes. Type 2 diabetes is characterized by the development of tissue resistance to insulin. This is not a problem of autoimmune destruction of the beta cells. This is a problem with the way the insulin works, and then a relative insulin deficiency with the pancreas failing to keep up with the high demand. So there's insulin circulating. The beta cells are working overtime, making lots of insulin to correct the hyperglycemia. However, the tissues are resistant to insulin. They're just not responding to the insulin. So this puts demand on the pancreas to make more and more insulin, and after a while, it just can't keep up. We talk about the pancreatic islet cells burning out. So these patients are producing lots of insulin early on, but eventually, as the pancreatic beta cells burn out more and more over the years, these patients may require therapeutic insulin. So let's talk about the key differences between type 1 and type 2 diabetes. You've got to be able to tell them apart for your exam, very important. So type 1 diabetes is caused by autoimmune destruction of the beta cells. Type 2 diabetes is caused by insulin resistance and relative pancreatic insufficiency. So we mentioned that type 1 is linked to specific HLA genotypes. With type 2, there's no HLA connection, but there is definitely a strong family predisposition. In fact, type 2 diabetes is much more likely to run in families than type 1, which can be hereditary or sporadic. So the age of onset, as we mentioned, is usually younger than 20 years old for type 1 diabetes and usually older than 40 years in type 2. Now, in real life, you can have adults diagnosed with type 1, especially young adults in the 20s and 30s, and there can be children and definitely teenagers diagnosed with type 2 diabetes. Statistically, though, younger patients will have type 1 and older type 2. So let's talk next about body type, particularly weight. Type 1 diabetes can happen to people of any weight, but since they're usually young and have been losing weight due to the undiagnosed diabetes, they tend to be thin. Type 2 diabetes is associated with obesity, which increases insulin resistance. It's always important to consider the whole clinical picture, like the age, but 7 out of 8 patients with type 2 are going to be overweight or obese. Under acute complications, it's important to know that patients with type 1 diabetes can get diabetic ketoacidosis, or DKA. With type 2 diabetes, people can get HHNS, or a hyperosmolar hyperglycemic non-ketotic state. We'll talk about HHNS later. And people with type 2 can also get DKA, but it isn't very common. And then under treatment, type 1 diabetes has to be treated with insulin. We made that point. Their beta cells are shot, so they can't make any of their own insulin, so you have to replace it with exogenous insulin. Type 2 diabetes, on the other hand, can make some insulin. It's just a matter of making enough to overcome the insulin resistance. So there are various oral medications that either stimulate the beta cells to make more insulin, or oral medications that help the liver and muscles be more sensitive to the insulin that's already present, or even drugs that can remove sugar from the body directly. But we'll talk about that when we get to the drugs for type 2 diabetes in a little bit. For risk factors and predictors, we mentioned family history, we mentioned obesity, we mentioned age older than 40. Metabolic syndrome is an important association, and we'll talk about that at the end of this video. Lack of exercise and sedentary lifestyle is a risk factor. Race, specifically non-white race, is a predictor, and gestational diabetes is an important predictor. Gestational diabetes is not just a problem during pregnancy. 50% of people with gestational diabetes develop type 2 diabetes later in life. Type 2 diabetes is often asymptomatic early on, and then there's gradual onset of symptoms. So remember, type 1 diabetes tends to have a rapid, acute onset, but type 2 diabetes tends to be a more gradual onset of symptoms. They get the same symptoms though: polyuria, polydipsia, polyphagia, all due to hyperglycemia. And another sign of type 2 diabetes to note is acanthosis nigricans. Acanthosis nigricans is a dark, velvety, kind of dirty-looking patch on the flexural areas, usually on the back of the neck, sometimes on the axilla, or various other places. This is associated with insulin resistance, so that can be an early sign of type 2 diabetes. The patient presents with new onset of acanthosis nigricans. You want to check blood sugar and see if they've got diabetes. A fair number of patients can get symptoms related to the long-term complications of diabetes before the diagnosis is made. So, for example, a patient may present with diabetic eye disease and be diagnosed by the ophthalmologist. A rather big percentage of patients, like 20%, can already have neuropathy symptoms when they're diagnosed. So when you see these signs, you need to check the blood sugar. Initial presentation with the late complications especially can be a problem for patients not getting routine health care. And patients who come in for regular checkups and get some blood drawn usually are going to be found earlier on in the course of illness, and with earlier treatment can avoid some of this issue. So the labs for type 2 diabetes are similar to the labs for type 1 diabetes. You're going to have elevated blood sugar and elevated hemoglobin A1C. And the diagnostic thresholds for these tests are the same for type 1 and type 2. All right, now we're finally ready to talk about treatment. Very high yield, 4-star topic. Initial therapy really includes two things: lifestyle changes and metformin. So for lifestyle changes, we're talking about diet, exercise, weight loss. Specifically with diet, we're talking about reduced calorie intake, reduced carbohydrate intake. And that's the first thing, and actually the most effective thing, if done well, for patients to think about with new diagnosis of type 2 diabetes. And this usually requires some formal education, visit with a nutritionist, and diabetes education. And of course, if lifestyle changes were easy, everyone would make them. But we still have a lot of diabetes out there, so that's why we go ahead and add medication early on most times. The treatment guidelines published by the American Diabetes Association say that you should start metformin as soon as the diagnosis is made, because getting the hyperglycemia under control quickly is very important to prevent all the complications like nephropathy, neuropathy, and retinopathy. And metformin has been around a long time, and it's inexpensive, and it's very safe. So we start out with metformin right away in most patients, in addition to the lifestyle changes. I'm going to emphasize that one more time. First line for early type 2 diabetes is lifestyle changes and metformin. I want to cover metabolic syndrome because this is closely associated with diabetes, so this is back in your study guide. What are the criteria for the diagnosis of metabolic syndrome? You need to know what these 5 things are, although don't spend a lot of time memorizing the numbers. Just take home the idea. The diagnosis is based on any 3 of the following, so you have to have 3 out of these 5. The first one is abdominal obesity, defined by a waist circumference greater than 40 inches in men, greater than 35 inches in women. Not all patients with metabolic syndrome are obese. This is just one of the criteria. You can be skinny as a rail and still have metabolic syndrome. The second one is triglycerides greater than 150, HDL less than 40 in men and less than 50 in women, blood pressure greater than or equal to 130/85. So they don't have to have full-blown hypertension. They could just have pre-hypertension. They could have blood pressure that's 131/86, and it may not technically be hypertension, but it could meet this criterion for metabolic syndrome. And then the fifth one, prediabetes or diabetes, defined by fasting serum glucose greater than 100 or a 2-hour glucose tolerance test value greater than or equal to 140. So remember, the diagnostic cutoff for diabetes was glucose tolerance test value of 200 or greater after 2 hours or 126 fasting. So you don't have to have glucose that high to be diagnosed with metabolic syndrome. If it's a little bit abnormal, you could still have metabolic syndrome. So again, the 5 are abdominal obesity, triglycerides, HDL, blood pressure, and fasting glucose. And metabolic syndrome is a constellation of findings and not an independent disease, but it definitely is associated with high risk for cardiovascular problems, stroke, and other things. It's very common. So while we're talking about obesity, I want to spend a couple minutes discussing options for weight loss other than lifestyle changes, which of course are part of any weight loss plan. So there are a few medications for weight loss indicated for patients with BMI greater than 30, and in some cases greater than 27 with comorbidities like type 2 diabetes. So there are amphetamines indicated for short-term use like phentermine. These result in a good bit of weight loss, but do have some dangerous risks, as you can imagine. And also patients tend to regain weight with discontinuation. There's a phentermine topiramate combination pill that's indicated for longer-term use, results in about 5 to 10 pound weight loss over 6 months on average. There's lorcaserin, which should help with central appetite control at the serotonin receptor, although the effect is weak and there are potential interactions with other medications affecting the serotonin system like SSRIs. And then the injectable drug for type 2 diabetes, liraglutide, has just received FDA indication for weight loss as well, and we'll talk more about this one in the lecture on type 2 diabetes therapy. And there are a few others, but nothing that I would expect you to see on your exam. All right, now surgical weight loss therapy is very effective, so let's wrap up this lecture with a moment on this. There are a couple of different approaches. First are the restrictive procedures, where the stomach size is reduced by either an adjustable band around the middle or just sewing off a small pouch called a sleeve. Weight loss with this type of procedure is entirely dependent on reduced food intake on the part of the patient. So weight loss on average is about 30 pounds. And then the second approach is gastric bypass, which again creates the small gastric pouch, but then connects this downstream on the small bowel. And the mechanism of weight loss here includes the restrictive part, as with the other, but also malabsorptive, because the food doesn't travel the entirety of the bowel. The average weight loss with this type of procedure is much greater, close to 100 pounds, although obviously it's associated with a bit more risk. So with gastric bypass surgery, we often see diabetes remission, improvement in dyslipidemia, hypertension, sleep apnea, and actually reduced all-cause mortality. And bariatric surgeons do their best to choose patients who will be successful with these surgeries, and prior to the procedures, patients are referred to cardiology, GI, and importantly, psychiatry for evaluation of stress or emotional overeating, binge eating disorders, or uncontrolled psychiatric disorders. These patients have to be on a very restricted diet. It's a big lifestyle change. Complications of gastric bypass, not the purely restrictive procedures, may include nutritional deficiencies in iron, B12, folate, thiamine, and vitamin D. And patients can also get something called dumping syndrome, where food is not processed in the stomach, it's just dumped directly into the intestine downstream. And people get bloating, swelling, and cramping. And with any kind of bariatric surgery, patients can get some GERD and even vomiting, especially when they try to overeat. All right, now it's time for the end of session quiz. Answer those questions, then we'll go through them together. First question, what are the underlying derangements in type 2 diabetes? Insulin resistance and relative insulin deficiency. What are the 5 categories of criteria for the diagnosis of metabolic syndrome? Abdominal obesity, triglycerides, HDL, blood pressure, and fasting serum glucose. Next, what skin finding can be a sign of insulin resistance? Acanthosis nigricans. Acanthosis nigricans is also associated with occult malignancies, but mostly I want you to think about insulin resistance. All right, what lifestyle changes are recommended for patients who are newly diagnosed with type 2 diabetes? There's diet, reduced calorie, reduced carbohydrate intake, exercise, and weight loss. And what drug is recommended as the first-line therapy for these patients? Metformin. All right, that's it for this video. See you next time.